Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
So I talked about a couple of abstracts from ASH, presented at ASH this year, and one of the most important probably was the late-breaking abstract 4 with post-transplantation cyclophosphamide, tacrolimus, and mycophenolate, GVHD prophylaxis randomized to tacrolimus methotrexate for patients with hematology malignancies undergoing transplantation with a reduced intensity conditioning regimen. This was a BMT-CTN study 1703, and this study showed that GRFS, GVHD-free relapse-free survival was significantly better with post-transplant cyclophosphamide, tacrolimus, and mycophenolate as GVHD prophylaxis compared with tacrolimus and methotrexate. It's important to note that the results were better because of lower incidence of severe grade 3/4 acute GVHD, yet relapse rate and overall survival was not significantly different. One limitation of this was the fact that ATG was not included in the control group for unrelated donors, and we use routinely ATG, and I'm concerned that if ATG would have been added, maybe results could have been different. Another interesting abstract was abstract 115, which evaluated outcomes of autologous transplant for high-risk myeloma based on presence of absence of plasma cells in the autograft, clonal plasma cells in the autograft, and the MD Anderson group showed nicely that persistence of clonal plasma cells in the autograft is associated with higher relapse rate and worse survival, both in patients, in patients with high-risk myeloma, but both those that achieved CR or VGPR and those who achieve less than VGPR response. And conclusion of the study is that it's important to have a graft that is devoid of clonal plasma cells for patients with multiple myeloma. Another interesting abstract was number 2101, allogeneic transplantation with high-dose post-transplantation cyclophosphamide for patients with acute lymphoblastic leukemia above age 55 years. This abstract showed that older patients in remission should get a lower intensity conditioning regimen, and patients had quite good long-term disease-free survival. 5-year relapse-free survival and overall survival for patients in CR1 for BCLL was 61% and 64% respectively, with lower incidence of relapse of only 16%, even lower if patients had TKI maintenance. Another interesting study was 2125, allogeneic stem cell transplantation for older patients with acute myeloid leukemia. This is an abstract retrospective study on more than 1,000 patients from MD Anderson, older individuals above age 60, which showed that older individuals can now expect higher CR rates or CR or CRI without the count recovery in the range of 70+%, similar to high intensity treatment with hypomethylating agents or low intensity regimens plus venetoclax. Venetoclax has clearly increased the CR rate, which enabled more patients, older individuals, to get to transplant. And in the more recent cohort, approximately 50% of older individuals were able to get to transplant. And patients who achieved disease control and went to transplant had better survival. Another interesting abstract was 2017, which showed that consolidation with allogeneic stem cell transplant for patients with a B-cell ALL who undergo CAR T-cell therapy is associated with a better overall survival. And while this was a relatively small study, the differences in survival were quite impressive, with a 1-year relapse-free survival of 81% versus 16% for patients who did undergo transplantation versus who did not. And of course, the failure for those who did not was because most of them relapsed. Another interesting study that I reviewed was number 362, a phase 2 study with posoleucel, an off-the-shelf multivirus specific T-cell therapy to prevent viral infections post-transplant. And the product is an off-the-shelf, again, multivirus CTL product against adenovirus, BK virus, CMV, EBV, HHV6, and JC virus. Administered early after transfer within first 50 days, between 2 weeks and about 5 weeks after allogenic transplant. Patients get repeated infusions every 2 weeks, and the group showed that the incidence of clinically significant viral infections after transplant appears to be reduced. Yet the number of patients was quite small. And there was a concern, I would say, with about 30% of patients developing graft-versus disease, grade 2 to 4. It is unclear from the abstract if this was de novo GVHD or a patient who had GVHD before received this one, although unlikely because the CTLs were administered fairly early after transplant. So it's likely that a proportion of patients developed acute graft-versus disease grade 2 to 4. Another abstract which I thought was interesting was 3,371, evaluating outcomes of older individuals receiving a transplant and the impact of developing of significant adverse effects and disability early after the transplant. And this was associated with significant decrease in survival, higher early treatment-related mortality, and a lower survival in patients who develops either altermentation, significant disability with impairment in function. ICU admission falls in the early post-transplant period, usually first month. This is again focused on transplantation for older individuals, which makes us think at ways to try to prevent this steep drop in disability free survival in these individuals early post-transplant, with reduced intensity conditioning, better selection of patients, geriatric assessment prior to transplant, and maybe other methods that one could employ to try to impact negative outcomes in this group early post-transplant. Another abstract which I thought was interesting was 3,371, evaluating outcomes of older individuals receiving a transplant and the impact of developing of significant adverse effects and disability early after the transplant, and this was associated with significant decrease in survival, higher early treatment-related mortality, and a lower survival in patients who develops either altermentation, significant disability with impairment in function, ICU admission falls in the early post-transplant period, usually first month. This is again focused on transplantation for older individuals, which makes us think at ways to try to prevent this steep drop in disability free survival in these individuals early post-transplant with reduced intensity conditioning, better selection of patients, geriatric assessment prior to transplant, better and maybe other methods that one could employ to try to impact negative outcomes in this group early post-transplant. Maybe one last abstract is number 2058, using haploidentical transplants for patients receiving haploidentical transplants with grandchildren compared with patients who receive haploidentical, older individuals who receive haploidentical transplant from children as donors. And in essence, the group showed that when they did a propensity score matching between patients who receive children and grandchildren, there were no significant differences in outcomes between the two groups, suggesting that grandchildren can potentially be used for older individuals in case children cannot be used or are too old to be used for transplantation. There were a few surprising things. One was I would prefer to have in the late breaking abstract for the randomized study post-Cy based GVHD prophylaxis versus conventional GVHD prophylaxis. One would like to see how patients with ATG, patients unrelated donors, receiving an unrelated donor transplants fared with addition of anti-thymocyclovine, which is fairly standard in many transplant centers. And another surprising thing to me was that the multivirus CTLs were associated with about 30% of the patients developed some significant graft-versus-host disease, which is a concern. I think these were the most surprising findings for me. An important aspect is we're talking about transplant. There were a couple of abstracts at this ASH meeting, and an important aspect was transplantation for older individuals. And we're looking at an abstract in AML, an abstract in acute lymphoblastic leukemia patients, transplanting older and older patients. More older patients can be taken to transplant. Outcomes appear to be improved. We're learning how to do the transplants for these patients, and I am optimistic that this trend will continue in the future, and we'll see more and more older individuals, especially with acute leukemia, reaching transplant. Not only because of better selection of patients, improving the way we do the transplant, but also better. In the case of AML, additional venetoclax appears to have made a big difference in terms of putting more patients in remission, and that would enable more patients to get to a transplant, and maybe they may be cured of their disease.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.